being recorded.
Oh, we are on. Good morning, everyone.
Morning.
Welcome back from our little summer sojourn. And hopefully, you all enjoyed because it went by real fast. Welcome to our Medical Professional and Information Technology Committee. If I can, I'd like to get a proposal for adoption of our minutes. They were from June 10th, 24.
So moved.
All right, so let me ask individually. Dr. Pagan?
Yes.
Dr. Martone?
Yes.
Dr. Katz was a yes.
Yes.
Okay, minutes have been adopted. So we can move on now to our action item. And that would be, Ms. Jalon will be presenting that.
Here I am.
Okay.
So I'm just introducing this on behalf of Dr. Eric Way, who couldn't be here. And we are going to be presenting on a cadre of services that Press Ganey provides for patient satisfaction and some other products. I'll read the resolution right now and then introduce the two colleagues that will be presenting. The action item is authorizing the New York City Health and Hospitals Corporation, also known as the System, to execute agreements with Press Ganey Associates LLC for the provision of care experience surveys, including patient experience, employee engagement, nursing excellence, and healthcare consumerism on behalf of the System for an initial period of 3 years and 2 one-year renewal options exercisable at the discretion of the System for an amount not to exceed $12,380,433 over the potential 5-year term. And now I'm going to turn it over to two of my colleagues who are really heading this work. Komal Lodari is the Senior Director of Care Experience, and Channing Thomas is the Director of Care Experience. So whenever you're ready.
Yes, we're ready. So thank you so much and good morning, everyone. As Hillary mentioned, we're really here to talk to you about the RFP process that we have undertaken over the past year or so to be able to contract with one or multiple authorized vendors who can do 4 things for us. One is our patient experience surveying work, employee surveying, nursing excellence, and this is really a body of work that supports how we capture and report data to then be able to support things like designations within the realm of nursing, for example, Magnet and Pathways to Excellence. And then the fourth body of work, which is a new addition, is healthcare consumerism, which is essentially a body of work that allows us to manage, monitor, and enhance our external image and reputation through digital and social media. The simplest way to put it would be what are our consumers, so to speak, saying about us on the internet, whether it's a Google rating or a Yelp rating and review, etc. And so with that, we can provide a little bit of context in terms of how we've done this process within the health system over the past few years. Typically, we contract with Press Ganey and have for over the last decade or so through a 5-year contract, just as Hillary mentioned. It has typically been a 3-year contract with renewal terms of 1 additional year, so 3 plus 1 plus 1. The previous or the prior period terminated itself at the end of June 30th, 2024. And so quite naturally, we've been in the process to now determine if we have the ability to continue working with them, Press Ganey, which is our current authorized vendor, and then or alternatively find another option or bunch of options that are better suited for what we are trying to do or where we're trying to go as a health system in terms of our strategy. So with that in mind, within our background and current state, you will note that our previous contract included only 2 scopes of work, which was patient and employee surveying. So we've added more over time. And the one thing that I would like to kind of highlight for us is that the reason this process is important is because some of our patient experience surveying work, as well as parts of the other scope of work, are contributors to us meeting regulatory requirements through CMS, but also public reporting requirements through other organizations, such as if we were to submit data for hospital safety grades through Leapfrog, or pursue designation processes for nursing or any other areas where we are seeking to provide data around our experience either as the workforce or as our community members. So with that in mind, it's important to just flag for everyone that a lot of these services are not things we can do in-house because there is a requirement for us to work with an authorized vendor. So really at this point, some of our goals internally with initiating this RFP process have been to find cost savings within the process. So anything we can do to either negotiate down the prices of services and products that we're receiving with the existing vendor, or subcontract out to multiple vendors for this work. And then also from a process perspective, to streamline how we're doing this work by taking all of these separate bodies of work and combining them into one sort of more comprehensive procurement endeavor. And then the last thing that I will share around this work is that we are currently within a 5-month best interest extension, given that our current contract ended on June 30th. So the 5-month best interest extension is on that same contract between July 1st and November 30th of this year. So in terms of the procurement process, which we'll go to on the next slide, we just kind of wanted to share more details around the process. So the minimum criteria that we set were that any vendor that goes through this process or applies to kind of become an authorized vendor for us. Can I request to move to the next slide, please? Thank you. Would be that a vendor has been in the business or has worked within these scopes of work for at least 5 years, will have similar experience in the 4 subject matter areas that have been outlined in the RFP, and have experience with servicing other integrated delivery networks or health systems such as ourselves. Our evaluation committee comprised of both clinical and non-clinical and administrative frontline workforce members, as well as leaders or subject matter experts that are really just utilizing these products on a day-to-day basis, but also using it to curate the strategy for utilizing them in the long term. So they're spread out across patient experience, employee engagement work, workforce wellness, quality, patient safety, human resources, enterprise information technology services, communications and marketing, data and analytics, and so many more areas. And also sort of balanced and spread out across all of the service lines within our provider realm, which is health and hospitals as a provider. On the next slide, we will quickly take a look at the scoring criteria for each of the 4 scopes of work. And something I will just highlight is that a vendor could have applied for any or many of these 4 scopes of work. So it wasn't necessary that they would apply to all 4. The other thing to flag is that we set the same threshold for cost and MWBE, which is at 10% each for all 4 scopes. So that was a maximum threshold that we set, and all of the other thresholds that we've set have to do with the content or the subject matter of the work in each of those areas. As I mentioned, the 4th scope of work, healthcare consumerism, is a relatively newer one, and we've been able to demonstrate its value through a pilot project with 3 of our hospitals so far over the last 6 to 8 months. But having said that, I'll just quickly provide an overview of those 3 substantive criteria that have been listed there. The first being listings, which is really just us being able to accurately reflect all of our contact information on the internet, whether it's a phone number, it's a website link, it's a physical address, the types of services we provide, etc. The second one is ratings and reviews management, which is really our reputation. So that's, imagine if you're going to a restaurant and they ask you to leave a review publicly on Google, let's say, as a consumer, you could leave a comment there. So we have the ability to now collate all of this information across different websites, if you will. You have Google, Yelp, and several others. So we are able to collate that information and actually be able to respond to comments and then redirect consumers if we need to other services we provide. For example, if we needed to follow up for additional service facilitation. And then the third piece is campaigns or consumer outreach, which is essentially us being able to reach out to patients who've received services or care from us to then be able to say, if you have received care from us and have something to say, please take a couple of minutes to provide this feedback to us. It's just an automated sort of email or text that we would send to get their feedback from them more instantaneously. On the next slide, you'll just see a quick snapshot of the timeline that we have gone through over the last year, as I had mentioned earlier, to be able to go through and do all of the due diligence needed to get this RFP in the place that it is today. So we've approached the contract review committee. To approve the RFP in the first place. We have then posted the RFP to the city record, connected with vendors to answer their questions if they had any around the substantive matter of this RFP process. Through that process, we were then able to shortlist about 7 vendors that met our sort of minimum criteria, who then were evaluated by our evaluation committee. 3 of those were then shortlisted to provide presentations to us, so we had a better idea of the look and feel of the products and services that they offer. And then from there was a second round of scoring by the evaluation committee to shortlist and kind of bring one or multiple vendors to the top for each of the 4 scopes of work. And as I mentioned, there are 4 scopes of work, so they were all evaluated independently. On the next slide, we just have a vendor performance sort of scorecard or spreadsheet that shows our evaluation in either yes or no on several of the measures highlighted here in terms of our existing authorized vendor, which is Press Ganey, and how we felt they fared over the 5 years. So we've sort of come up with a satisfactory overall sort of rating or evaluation, given that we've had a relationship with them for a long time, so they have a keen understanding of how our health system functions and are able to meaningfully meet our needs in terms of being a safety net health system and having more unique sort of challenges and circumstances to be dealing with or managing and sort of surpassing, excuse me, if you will. And so this is also based on our conversations with our counterparts in other health systems who have utilized Press Ganey. And this includes a combination of both private and public health systems, one in the safety net space, and then also others that have multiple facilities within the health system, both within the tri-state area and then outside of it as well. On the next slide, you'll just see sort of a quick snapshot of our rationale as an evaluation committee to getting to the decision of putting Press Ganey forward again as our next authorized vendor to work with. I did mention our existing sort of standing relationship with them. They also have the unique ability to meet all of our needs in terms of all 4 scope areas of work. And from an IT perspective, our evaluation committee members also emphasized the benefits of a more integrated approach if we have the same vendor working through all 4 scope areas. And the other benefit is that Press Ganey as an organization is also working with Epic, which is our primary health record, to be able to further integrate together independent of their relationships with clients, which makes it easier for clients to then see the work more coherently, and be able to develop strategy around it. Another sort of driving factor was that in our third scope of work, which is nursing excellence, we have already sort of set up or laid out the groundwork for us to pursue and win several designations through Magnet, as well as Pathways to Excellence, Beacon, and several other nursing certification processes. So not all the other vendors were able to display or demonstrate that functionality and expertise, which made Press Ganey a front runner there. They also have the ability to help us benchmark the data that we collect in a more meaningful fashion. Thinking about us being able to compare ourselves to other safety net health systems, regionally thinking about AHA Region 2 or even the tri-state area. They also have a lot of clients within the New York State as well as New York City. So we have a lot of opportunity to then be able to make meaningful comparisons for ourselves and then set goals accordingly to keep moving in a favorable direction. And then, as I mentioned, they've worked closely with us in the last year and a half to take the feedback we have provided to them, to partner with us and collaborate on curating any new or additions to their products and service offerings, to make them more meaningful to a context that is not private or maybe as resource rich as it might be for us in our context, and to think innovatively to be able to solve problems by leveraging smarter technology and better process design. With that, on the next slide, we will see a quick note about our vendor diversity commitment. So Press Ganey did submit a waiver with their proposal to say that they essentially have technology in place to be able to do things such as translation services, which is a huge requirement for the things that we do in these four scopes of work in terms of data we collect. We have a lot of free text or qualitative data, which can be in any of our many top 13 languages. And so they have the ability to translate this information and then continue to utilize their technology for further analytics. So that's the reason they've submitted a waiver. And they're also able to help us integrate with Epic. This is separate from the diversity statement on the slide. But are able to integrate with Epic to then connect our patient self-identified or recorded demographic information through the health record to then be able to apply an equity lens to any further improvement work we might do, which could be outside of language, but language is a significant one that we work with. And then, so in closing, I think just to reiterate what Hillary shared at the beginning, the goal for us being here today is really just to ask for this committee's approval in terms of moving forward with Press Ganey as our authorized vendor for an additional sort of 5-year contractual period, which would begin on December 1st, for the next 3 years with 2 1-year renewal options at our discretion as a health system. And the not to exceed amount is listed again on this slide. It is for the full duration of these 5 years and is inclusive of any inflation adjusted costs that we might see from any other vendor that we contract with, but their increases over time are still below your sort of standard inflation rates for any other products or services that we might see within the nation. So with that, I will pause, and if you do have any questions or comments or feedback for us, we're happy to hear them. And again, thank you all for your time.
Well, let me ask each member individually, maybe Dr. Martone, start with you. Any comments, questions?
Thank you.
Super, Dr. Katz.
No, as you've heard, I mean, this is necessary as part of an industry, right? It's not a scope of work we can do ourselves. It has to be an outside vendor.
Just happy that you added, excellent, and that you added the consumerism piece and the nursing excellence. So look forward to see how that evolves and how they actually do that in a way that it can be useful when they present it to everyone.
Sally?
I have just a general question. I know how unhappy we've been with the Press Ganey survey and how incredibly long it is to complete. And I guess that's because of the regulatory and certification requirements they have that require all of these questions. But on some surveys that I've taken, they'll ask 5 or 6 quick critical questions and then say, and now we'll turn to a more detailed set of questions. And so you're able to capture the shorter subset of questions, because I'm afraid we lose so many people. You know, I think people will start doing the survey, and at a certain point, it's just overwhelming how long it is. I don't know that we have any ability to modify that or to kind of get a quick fix on what the most critical indicators are that we're concerned about. Yeah, that's.
Would you want to
I
go
could
first?
start and then Komal can fill in where I miss. You brought up the regulatory environment and some of that's real. So for HCAPS, there's a specific set of questions that has to be included. And then there's other questions that really don't need to be, that are part of the survey. So I don't know, Komal, would there be a way to use that set of questions and then do something like, say, now you can go on and answer this next set of questions so that we can get more detail?
Yes, so it's true. We are sort of we are constrained by the regulatory requirements around what we survey on, and of course, CMS is our guiding force. Is also doing a lot of research to determine what are the right questions to ask. So typically, all questions on our surveys, irrespective of care setting, are based on a parallel or mapping to a patient's visit or encounter flow, which is helpful for us to kind of see how it works across the flow of the patient's journey. But with that, there is some good news. Specifically for our inpatient setting, our HCAP survey is undergoing some changes starting encounters that take place January 1st, 2025 and onwards. So the length of the survey is restricted by CMS. We cannot add any more than 12 questions, 12 extra questions if we had to the HCAP survey, which before this was pretty not regulated. So a health system or any provider could do as they pleased in terms of how many questions or what they wanted to ask. But having said that, something we also want to do is to be able to capture data more instantaneously, or not only have to think about our regulatory requirements. And that means contracting for other services, maybe more digitally friendly and forward, that help us get that information more instantaneously. And I would turn to our partners in legal and procurement and supply chain to really help us negotiate to be able to get the best possible deal, if you will, in our partnership with Press Ganey, so that we are able to collect feedback from multiple methods or modes. And then outside of the ones that are regulated, most of our surveys are about 20 questions in length or less and are administered by both paper or electronically by email or text survey links, which makes it easier because the surveys are in general short, and most good surveys, just by standard practice in survey design, will be 20 statements or less. So we do have that going for us, but the ones that are regulated are, I think, for inpatient pediatrics, ambulatory surgery, and inpatient, yes. So medical, surgical, hospital stays.
You just had within the body language about safety culture surveying. It wasn't, is it subsumed with one of your 4 categories?
Yes, it will be part of the employee surveying scope of work. So over the last 2 to 3 years, internally as a health system, we have also really taken stock of the number of times and the types of surveys that we administer to our workforce. So this is an effort over the last 2 survey periods for us to really join forces. We know that we have to do a safety culture survey every 24 months, which is every other year essentially, so once every 2 years. And so our employee feedback survey comprises of questions that touch on safety culture, overall engagement, well-being and resilience, diversity, equity, and inclusion. And I might be blanking on a couple of others, but it's a more comprehensive effort for us to collect all of that information in one go, which means we have more resources to support promoting the surveys and then also capturing meaningful feedback all in one go. And then, yes, then that safety culture survey data contributes to how we are doing corrective action within the health system to foster a stronger environment of psychological safety and then contributing to patient safety as well.
That's once every 2 years, Sally, the culture of safety survey.
Yeah.
Any other questions? I'm sorry, Dr. Allen?
So I didn't realize this question when we talked before. In terms of equity, do they give us race-based analysis? Among the English-speaking population, can we distinguish care or satisfaction based on race?
Yes, there are a few ways to do this. One is if patients are self-identifying their race and or ethnicity, and the other is for us to then feed the data we collect in Epic and connect it or integrate it with a patient survey responses. So that's sort of a back-end way to do it, but the data is there. It will only be as good as the number of times or the efficiency or consistency with which those fields are populated, either by patients themselves or by workforce members when we're sort of registering.
So it's us to do that. Press Ganey does that, include that in their analysis.
They can, and we also have the ability to self-service it. So as long as the data is captured anywhere, either on the survey or in Epic and then integrated with the survey response, we can pull our own reports. If you were interested in looking at that, our team can definitely put something
I
together.
was actually interested, how much of that is done by the vendor?
They can do customized analysis and reports for us.
We can ask them to do that.
Yes, we would just need to figure out our research question, so to speak, or tie it to some sort of program or project that we're interested in.
Because I don't remember, when I've gotten a survey, do they ask my race and ethnicity?
It depends on what service you received. Typically in the inpatient setting, and I'll just use that as an example since we've talked about it, at the end there are questions in an About You section that include questions around race, ethnicity, education level, a self assessment or understanding of one's mental health and well-being. I think there are some around age group also. So it depends on like where you received a service. Perhaps our emergency room surveys do not include those. I would have to look back at the others, but there are some where we're required to ask them, so they could be self-reported by patients,
Great, thank you.
of course.
Any other questions? Super. It sounds as if a great deal of this, though, is, to Dr. Allen's point, a lot of this information, once it comes to us, some of it is just basic data, and then we have to analyze, but it sounds like they've been very flexible, and it sounds like from what you're saying, there's a lot of ability to work with them to get things specific, I think, to us. And it'd be interesting to hear the other end of it once we have this data, whether it be in employee surveys or so on, just exactly how we have looked at it and are trying to act on it. So like the data we collect, okay, then what would we do with it? Where are we? How are we utilizing it to try to improve things? So excellent presentation. Thank you so much. Let me ask for a vote then. Dr. Matone, if I could ask you first. Dr. Katz?
Yes.
Say yes.
Yes.
And Sally? Yes. Okay, super. So motion carries, so we can get on to our reports, and Dr. Allen, you're on first. So,
As you know, what we do with the CMO report is to highlight work that's being done in MMPA. We talked about peri-op, women's health, a number of other things, radiology, teleradiology. And today we're focusing on simulation, and Dr. Megadushian is here.
Go up there. Or?
Yeah. Dr. Megadushian is an emergency room physician as well as leading our IMCEL lab, Institute for Medical Simulation Advanced Learning.
So good morning, everyone, and thank you so much. So my name is Michael Megardichan, and I'm the Senior Assistant Vice President for the Institute for Medical Simulation and Advanced Learning, and I'm also an ED doc working at Harlem Hospital Center, and love that job. But I'm really excited to be able to share some of the accomplishments that we've been able to achieve over the last year. So we can go to the next slide. So to orient you all with how we function within our system, I want to link some of the things that we do with the pillars with which we align. And so when we think about simulation, simulation creates education that helps build quality care and is focused on driving improved care outcomes. With its interventions, we hope to build, procedural skill and technical skill, but we're also thinking about what is the interpersonal care that's happening at the bedside. Through debriefing conversations, we look to build psychological safety, flatten hierarchy, and really create a flow of communication and active listening that will make our organization stronger. And lastly, we look to build programs that build financial sustainability as we look to drive down litigation claims and payouts through the improved quality of care. Go next slide. And so how do we do this? We keep laser focused on our vision, which is the Institute for Medical Simulation and Advanced Learning offers innovative, safe, educational, and quality-driven opportunities to support and promote the highest quality, equitable care outcomes to the patients of New York City Health and Hospitals. And in order to do this, you just hit a little click there and move to some of the infrastructure. We do this by having programs supported by our hub at Jacobi, as well as satellites at Elmhurst, Kings County, Harlem, Lincoln, and Corrections Health. And we're also working on building centers at Queens Hospital, and as well as thinking about building at South Brooklyn. Next slide. Next click. We also have OBGYN mini labs, We also have OBGYN mini labs over at Bellevue, Elmhurst, Harlem, Lincoln, Kings, and Jacobi, focusing on maternal health. So I want to introduce to you what is healthcare simulation. So I put together a little quick video for you to understand what does this mean when I say what is healthcare simulation. Is there sound? No? I guess there's no sound.
Hold on a minute, the video is.
What's that?
Hold on a minute.
I could talk over it too. That's another option. I can tell you, I've looked over this thing 44 times.
You can go ahead. Talk over it.
All right. So, what is healthcare simulation? Healthcare simulation essentially is looking to recreate clinical experiences, to think about a variety of different things. And what it does is it creates an experience that we get to reflect on. And so, not only does it do it with creating educational experiences, but we can also think about quality improvement. It does it in a way that allows us to practice in a clinical situation and make mistakes. And so we can use this technique to explore everything from policy and procedure, build knowledge, think about how to do procedural skills. We can do it to actually think about how we build spaces. We do things like doing a secret shop room where we go into clinical environments and pretend to be patients to explore how we're dealing with situations like Zika virus. Even thinking about, like, right now we're thinking about dengue and other disease things going on. We're also thinking about how you have bedside experiences with using this technique. And we do this using a combination of robots that blink, breathe, have heartbeats that you can do procedures on. We do it with virtual reality, where we put you into a virtual room and you get to experience what's happening and interact with the different simulated beings in there. We also use patient actors to be able to recreate bedside experiences. And lastly, we use debriefing to really engage in conversations that make you think about why I did what I did. Did I have the knowledge? And what stopped me from moving that knowledge forward to actual action? And so now that you have a little better understanding of what is healthcare simulation, I want to take the chance to focus on a couple programs that we're doing within our system. Next slide. So first and foremost, we run and support 25 programs throughout our system, focusing on things from how do you manage a difficult airway, for example, when a person is circling the drain and need to have their breathing protected. How do you do a trauma surgery using the Kutsu program, where we actually have real surgery happening, allowing residents to make mistakes without the attending reaching in over them so that they can learn from their mistakes. We also are running programs that are allowing people to practice laparoscopic skills or colonoscopy skills. Imagine going in for your colonoscopy and there's the first time somebody sticking a colonoscopy up you without having practice. We create those practice situations and allow people to make mistakes and learn from them before it impacts clinical environments. Next slide. We've also created and are running the largest simulation interprofessional fellowship in the world. We have graduated 100 fellows from that program last year, and this year we have 15 interprofessional fellows from all different walks, including respiratory therapy, we've got anesthesiology, we've got nursing, we've got midwifery. It really runs the gamut, and that allows us to practice interprofessionally within the educational setting so that we can then allow them to go back into their clinical environments and bring those experiences to the bedside. We've also been accredited through the Society for Simulation in Healthcare in all 6 areas: core, assessment, research, teaching education, systems integration, and fellowship. And we join only 30 programs in the world that have been accredited in these 6 areas. Next slide. And this year alone, 2024, meaning starting from January, we've already had 15 national and international presentations, as well as 6 manuscripts published or submitted in 2024. Actually, I said this earlier in the practice meeting. One of my publications got accepted about 2 weeks ago with minor revision, so like a big deal, really cool, about bias debriefing conversations and how they impact learning outcomes. Next slide. So let's think about some of the programs that we're actually running. So COVID really left a big gap in terms of education for nursing, because a lot of nurses graduating from their nursing school with not much clinical experience. And so partnering with Dr. Saneas in nursing, we were able to help support a program where we have nurses going through experiences in emergency medicine, critical care, and the operating room. So for example, how do you deal with a fire in the operating room? We can recreate that experience and allow people to go through the motions of what happens. How do you deal with a ventilator that's alarming in a critically ill patient? We have our nursing educators and our sim team working together to recreate that experience so that nurses are better prepared when they hit the floor. And since we've started those programs, we're looking forward to starting a pediatric ICU and an OBGYN program in Q4 of 2024. This has actually impacted a significant amount of our volume. And you can see in 2023 that we had a total of, I think it was 2,911 learner encounters. This year, up through July, we've already had 4,121 learner encounters. So we will double our learner encounters by the end of this year, and at that same rate be able to probably quadruple in 2025. So our utilization is popping, so to speak. Next slide. Another program I want to focus on is our maternal mortality reduction program. Women of color are 4 times more likely to die during childbirth, and prenatal care, acute care management, and implicit bias all contribute to these figures. Next slide. Or next clip. And so partnering with Women's Health and Maternal Medical Home, we've created a simulation program that is focusing on the situations that are most dire. Situations like OB advanced care life support, when the mother dies during childbirth. Postpartum hemorrhage, when the mother is bleeding significantly during childbirth, shoulder dystocia, when the baby is essentially getting stuck during transition to coming out, hypertension in pregnancy or preeclampsia and eclampsia. How do you handle a situation where pregnant patients are at risk of having a seizure? And we're going to be moving towards situations where sepsis in pregnancy, as well as venous thromboembolism, all these are things that are really creating serious high risk for our pregnant patients. And we've built those 6 obstetric gynecology mini labs across the system in order to help with training. And you can see in this picture, this is a practice situation during one of our simulations where we use hybrid simulation, where you have the interaction with the patient, but at the same time you're dealing with a birthing situation that's recreated. And so in this situation, it's a maternal hemorrhage. So the mother is bleeding, and the OB team has to respond accordingly to make sure that they are able to stop the bleeding and hopefully save both the mom's life as well as her uterus so that she can have future pregnancies. Next slide. And so last year we focused a great deal on pregnancy, hypertension in pregnancy or preeclampsia. And we trained 2,500 people within the clinical environment, which is an incredible number. And as we move forward, we're trying to make sure that we've hit a saturation of 85% of all providers in that care. Next slide. And with our postpartum hemorrhage work that we did in 2021, we're looking at data between 2020 and 2022, and we've gone through 3,000 charts and to validate 7,000 patients over that time. And we're looking to see the outcomes of use of tranexamic acid, which is a life-saving medication, use of uterotonics, stage of bleeding, meaning how badly did they bleed, did they get a hysterectomy? Did it impact the length of stay in the hospital? Were they transferred to the ICUs? And even though we're in prelim data, we can confidently say that the use of TXA has gone up across the system. And especially in those particular departments that don't have specific policies addressing TXA, the education is having an impact. Next slide. And lastly, I want to talk about opioid use disorder program. Opioid use has seen a significant rise over the last decade. Mortality rates, and Dr. Bowden and I were talking about this earlier, it's the same as having a heart attack. If you have an overdose situation, it's the same as having a major heart attack. Your mortality is 5 to 10% in the next year. And lack of access to care, bias that we have as providers, as well as an unfamiliarity with treatment protocols like buprenorphine, are all contributing limitations to our ability to have these patients access care well. Next. And so you can see the numbers. In New York State alone, we've actually gone from 1,000 about 10 years ago all the way up to 5,000 deaths. In the country, it's an epidemic, 100,000 deaths per year. That's crazy numbers and something that we need to do something about. So, next slide. Partnering with the Office of Behavioral Health, targeting emergency medicine providers, because that's where a lot of those patients access care. We've been creating simulated patient encounters, meaning actors are actually coming and playing the roles of patients who are suffering with substance use issues. And working with those providers, we're dealing with the art of creating rapport with those patients to hopefully create the opportunity to offer them an intervention, to diagnose withdrawal appropriately so that we can offer the right medications for these situations, ordering and prescribing buprenorphine, which is a really life-changing medication that I will tell you, even myself, I learned from being part of developing and attending this program, and reframing substance use as a disease. Substance use is diabetes, right? It's a disease and it needs to be appreciated as that, as well as addressing stigmatizing language that creates barriers for patients wanting to receive care. And so you can see in this picture, you can see this in this picture, a provider practicing the interaction with a substance user in a very familiar situation where the substance user is now sober and wants to leave. And so how do you get that moment to make a difference? And so we practice what language are you using, what strategies are you using in order to make that situation one that's going to make a difference. Next. And so we're looking to see how we're doing. And we have the ability to look at things like, are we ordering and prescribing buprenorphine? Are we ordering methadone? Are we using our ED leads and catch teams to be able to link people with detox? And eventually, we're going to move through the DOH data and see whether or not we're increasing detox placements, as well as monitor return visits to the emergency departments. And so right now we are, the number's actually going to by Thursday should go up to 84 of approximately 1,000 providers and all the residency programs throughout the system in emergency medicine. Metropolitan, Harlem, Jacoby, and North Central Bronx have been our pilot that we should be done by Q4. And I'm looking forward to extending this program to nursing and to other areas because this doesn't just happen in the ED. Next slide. And so we do this with 11 people. And we do this with partnerships. And we do this by adding to those eye care values we add mutual support, innovation, and service. And in order to do all that, it takes a lot to make sure that we interprofessionally make it happen. So I'd like to thank you so much for your time and open it up to any questions.
Questions? Fabulous, President. We've come a long way from see one, do one, teach one from my day, which is a great thing to hear. Just curiosity, though, as far as, I mean, this is magnificent. And the bottom line is, no joke, probably from medical school for the doctors, nursing school for the nurses on, and certainly the residents should be hopefully being able to take advantage of programs like this. How do you see that? Is this something that we can see extending? Is it done, collaboratively with some of the training institutions and so on? How do you see all that going?
So we have been making a partnership with CUNY in order to get both CUNY Med School, and I'm hoping that CUNY Nursing, the PA school, is part of the work that we do right now. And we're trying to allow them to come into our actual centers and do training. And what I'm hoping to do is to create interprofessional training, because at the end of the day, we all practice together, and that's how we end up performing. And so I want to practice as we perform. There are a lot of inter-health professional schools that do not include medical schools, unfortunately, that have already started this trend, but I'm hoping that medical schools will catch up and catch on, because we need to practice communicating with one another before we leave medical school. But I will say that we need a lot of practice in how we communicate, because the reality is that we've kind of practiced a lot in silos, and we've got some bad habits that we got to break away from.
Any questions, comments? Super, great presentation. Thank you.
Thank you so much.
Thank you, Michael. All right, Dr. Sineas, nursing.
Good morning. Our nursing work continues to be steady and progressive towards nursing excellence. Next slide. Oh, perfect. So we have just completed the Care Delivery Daily Management System training at Jacoby. Jacoby is the 8th hospital within the system to have this training. So it entails a week-long training for the nurse leaders. So we trained 33 nurse leaders and 900 staff nurses. We're now at 93% of all of the staff nurses at Jacoby going back to the basics of nursing practice. And so we're really proud of this work. We hope to be at Kings County in October. Next slide, please. Our biannual report celebration was held and on May 31st, where we celebrated the last 2 years of work in partnership with NISNA. This is essentially a culmination of all of the work that we've done. This is an opportunity to pause and reflect as we think about the future strategy, but also just take some time to celebrate our accomplishments. Next slide, please. We also held a fireside chat where I facilitated a conversation with our IT partners looking at nursing informatics and documentation. Our goal is really to reduce the redundancy within our documentation system post-COVID. So there's a lot of opportunity. Over 300 nurses were in attendance and are really eager to look at streamlining different processes within Epic. Next slide, please. We also have been celebrating Beacon Awards, and so at the NTI, the National Teaching Institute in Critical Care Exposition on May 20th to the 22nd, we celebrated 6 gold and 6 silver Beacon designations throughout our system, which entailed celebrating Bellevue, Kohler, Harlem, Jacoby, Kings County, Lincoln, Metropolitan, Queens, and Woodhull for their excellent care within the critical care units. Next slide, please. I'm proud to announce that we've had so far 3 of our emergency departments also recognized. So Metropolitan and most recently Queens were designated just this past weekend for the ENA Lantern Award, which recognizes emergency departments that demonstrate exceptional and innovative performance in leadership, practice, education, advocacy, and research. And this is really important. As we hire new nurses, we have identified that many nurses want to work at facilities that are recognized and designated for excellence. And so we're really proud of our hospitals. Next, the Nursing Clinical Ladder, which is a professional development program in partnership with NISNA. We've had 2,622 individuals that have been approved. We've seen a 25% increase in number of applicants and also a 23% increase in the number of approved participants. This is important. We track these metrics because these metrics are indicative of nursing engagement. And the more our nurses are engaged, the more that they will stay within the system as they grow and they develop throughout their careers. Next slide, please. Certification, we have a grant that allowed us to build and to integrate Nurse Builders, which is a cloud-based certification review course with 34 certification review courses. Our goal was to have 1,000 nurses enroll in the program, and we've had 2,416 registered nurses access the platform to take certification review courses. And so we're really proud of this because certification is the hallmark of nursing practice. Just a couple of other announcements. We continue with our professional shared governance, our nurse residency program. So far, our 2024 retention rate is 100%, and our overall program retention rate is 85.9, which surpasses the national benchmark for the nurse residency program. Our ED fellowship program is also successful. As Michael mentioned, we cannot do it without our simulation partners. We've had 358 nurses enrolled with a 100% retention rate of all our new graduates working in the ED and also the critical care fellowship. We see a strong retention rate as well with 51 enrolled fellows in the critical care fellowship. And we've also started an OR fellowship. So in order to hire new graduate nurses in critical care spaces, we have to have fellowship programs. And so we quickly stood up these fellowship programs with the support of simulation. And right now we are piloting our OR nursing fellowship program. The pilot started July 29th for Harlem, South Brooklyn Health, and Woodhull. And so we're really looking forward to the growth of these fellowship programs and to supporting our new nurses in critical care spaces. That concludes my report. Thank you.
Congratulations, excellent report and amazing work you've done. I think we all are amazed by it, and I thank you. Any questions at all?
I just talked to the head of NISNA about a different issue, and she wanted to say, how great she thought the collaboration was between NISNA and health and hospitals, and that has not been historically true, as you know.
For sure.
Just a quick comment. I mean, I like how you've been thinking about career ladders for nurses on the leadership side, but also on this whole issue of certification. And I'm glad to see that you had a lot more participation than you expected on that. So,
Thank you.
Excellent. Thank you. All right, let's move on to the Chief Information Officer report. Dr. Mendez.
Yes. We could go to the next slide, please. Right. So in keeping with our process, we are going to focus a little bit more on our Going Green Unprint roadmap. We have developed a program for a 5-year reduction of printing across our system with a focus on sustainability. But just a little prelude as we get to that slide is you'll see enclosed here a high-level overview of our fiscal year 2024 key results from our goals, and we'll actually be showing our 2025 OKRs in our next presentation here. I did also want to highlight that we have inaugural EITS Employee Recognition Program. It's called the EITS Stars of Excellence. This is the first time that we've held this, and it has been really such a very positive experience. We'll be having our award ceremony on September the 17th, which is National IT Professional Day. And then in addition, we can move through the slides, David. In addition, just wanted to highlight what our EITS Applications Learning Team is doing. It used to just be the EPIC Application Learning Team, but we have actually expanded way beyond EPIC, and this has really been very useful in both the clinical and the non-clinical areas and all the software across our system. And it includes provider personalization, and technology fairs, our new resident EPIC training, and super user training, as well as we've recently had, we call it our Thrive program. Once you've had the initial EPIC training, then you get additional training, and we recently had it develop a program for nursing as well as our financial team. And if we can go to the unprint slide, David. So Going Green Unprint is a 5-year program that actually Jeff Lutz's team has put together that will begin to look at where we will focus starting in 2024. There you go, we can stop on that slide. Thank you very much. This is to help us develop a repeatable process that we can launch across our entire system, with the main focus being on a sustainable system, as well as lowering our overall printing and lowering our color printing across the system. We will be piloting this at central office, and thank you, Dr. Allen, for volunteering your department to go first, as well as others here in central office. We can go to the next slide. One of the key things that will drive the success of this program is really, we're calling it SEEDS, but the key 5 process steps, which is where we'll go into each area, we'll identify a champion in the area, we'll look at the current workflow and how you're doing the printing, we'll come up with some established goals that are unique to that department. Everybody is different in in the workflow that they have and their printing needs. Then we will deploy those improvements, and then we will have the benchmark, and we will measure success across each of the different departments. And we're able to put data at every department level. Next slide. And part of this is also what we're calling our marketing strategies, and this is where a lot of the work has been taking place up to this date. And here we are developing a new website that will be focused in EITS for all the different options that you can have for not printing. It'll have links to education. It will also be, the links will be embedded in your current workflow process, so it's easy for you to gain access to. And we've refreshed some of the slides as well, so that they're easy to read, easy to understand, and they're catchy as well. Next slide. And this is our 5-year roadmap. As I mentioned, we have already had our initial planning that started in July. We are preparing to kind of kick this off in late September, early October at central office. We will start with Dr. M&PA, but we will spread that quickly across the entire area. And we will have quarterly reviews for the first 3 years, and then I think we can move into a biannual review after that. Next slide. And this is how we are going to do it. I think it's important that after we do the plan, the build, and the launch, and we start at central office, we will then transition out across our entire system. Our first focus after central office will be on enterprise administrative offices at the C-suite, so that we can, talk to those who are leading our organizations and have them really be the champions as well. And then we will go to a service line alignment. And here is where we are looking at high utilized areas. One is HIM, another is HR, and we know that even in EPIC, we do a lot of printing from EPIC, and so that's a key area for us to focus on. Next slide. And these are some of the key deliverables that we are looking at that I had mentioned about putting unprint pop-ups and redoing our website, et cetera. We can go to the next slide. And we are moving along with some of our first deliverables, and we are ready to actually launch this at the end of September. And so you can actually anticipate that you will see us here at central office. I will say that Ishmael Miller is our director and our champion of this initiative, along with Jeff Lutz. So we are really excited to begin here and then put our benchmark data down and then move it across our system and measure our success. And we can close there for any questions.
Questions?
So at these kind of meetings, will we be paperless?
We will work with central office to develop a strategy. And actually, I will say that I had looked at the paper here, and it was before there. You do not see the PowerPoints in here, and I do not see color printing in here. So I thought that was actually a positive direction, to begin with. And I did also notice, I just want to say, Natalia, I noticed that you were reading everything from your phone today, so Natalia gave her report totally without paper. So kudos to you.
I'm trying.
As long as we're doing improvement, I mean, a big thing that we're working hard to do is on internal things, get rid of this.
Good point.
Because this, the color border is what then forces the color printer. And it's, the dyes are incredibly bad for the environment. So, obviously there's value in it in a marketing strategy, but to ourselves, we don't need our fancy border, right? We know who we are.
Questions, comments, any others? All right, our last report. Thank you so much. Metro Plus Health Plan, Dr. Schwartz.
I know we're out of time. I'll be very, very quick.
But how big is our membership?
Important to not get that answer.
684.
Start with that. What is
684,
684, right?
the current number.
I mean, is that not in and of itself amazing, right? Because people have a choice, right? Nobody has to go to Metro Plus Health, right? They have a choice of a variety of other plans. And the fact that our plan has been growing so much is a testimony to the quality of the services that the plan is providing.
Yeah, no, we're very proud of the number, especially in light of the recertifications, right? We're now 1 year into it. We know that the state average and our average is around 80%. So the expectation was to lose approximately 20% of the population. And we were able to mitigate the recertification and reintroduction. And so we certainly have done better than expected. In terms of the research rates, we are on par with the state. And we have several lines of business that have significant growth, especially around Child Health Plus, and also around our commercial lines of business, in addition, obviously, to our more traditional lines of business. So I couldn't agree more with Mitch. We're focusing on areas where we know there is more opportunity in terms of the research. The enrollment and the recertification is not happening only by our own enrollers and health and hospitals. There are navigator organizations who do the enrollment and then the renewals. And we see that the renewal rate with those organizations is lower than it is for our own enrollers or H&H. So that's where the focus is, to help and support them so that the research are more on par with what we're seeing in the 80th percentile. I will tell you that where we see the highest rate of research is our sales folks. So if a sales enroller enrolls the person, they will go back to that person and will help them to renew. And in the last several months, their success rate was 85%, which is really unbelievable. Since we're out of time, I just want to mention quality. So we got our quality results for our HIV SNP plan, and we are again #1. I'm very, very proud of it. It doesn't just happen. There are actually more and more expectations from the plans to provide much more comprehensive care management, not just to manage the HIV aspect, but really a holistic approach to those individuals. And so we've done well both on kind of the general quality aspects, but really importantly on the viral suppression aspect. We've been doing well there, and we were able to sustain it. So very proud to report that we continue to be #1. And I will conclude here. I know we're out of time, so that will conclude my report. Thank you.
But not too short for questions.
Just a
Sally.
question. Elmhurst has the best recertification rate and Gotham the lowest. What are their recert rates, do you know?
I don't remember off the top of my head. I think I know Elmhurst is around the 80th, 82 or so. I
Right.
don't remember what it is for Gotham.
Yeah, I was just a little concerned about Gotham, but it depends. I mean, if it was 79, then there's nothing to be concerned about.
No, it's lower than that. There is a meaningful gap. that I'm able to say.
Is that because do they need help with the navigator agencies or more salespeople? How can we help?
So there are a few factors to it. I can't really speak on their behalf, but yes, supporting with people who are able to recertify certainly is one of the solutions. Yes.
Okay, any other comments, questions?
No, great
Super.
work.
No new business, no old business, therefore we are concluded. Meeting is adjourned. Thank you all.
Appreciate it. Thank you.
This meeting is no longer being recorded.